why we have this Genome of Europe, and which starts, actually it's approved. And we also have this genome data infrastructure, which really makes platform to keep this data, to have a look. I don't really want to use the word sharing, because we are not sharing basically data, we just make it accessible, because people are afraid if you say we are sharing your data, we will, oh, how do you share it? You send it to the, which country you send. No, we just keep the data in our country, but it's accessible. And that's why we need all these cross-border tools to do it in real life and time. So this is one thing. Other thing is that genomics has been used for rare disease for a while, and the problem there was that I'm a medical doctor. I work on genomics, so you have a family with sick child. You sequence them all, and then you find a variant, but it's so rare. You don't know that whether this particular variant is responsible for this phenotype. So you have to go to literature, and I remember we were looking for literature for 7 months, and finally somebody from Arizona published the same variant and same phenotype. So we were more or less sure that this is now the thing. But if we have this database available, it would take like microseconds just to go to the database and have a look, and you see that this mutation has been discovered in few other places, and you just can move forward. And in many cases, there is a treatment available. You just go ahead. So it's immensely important to have tools to share the data, again, to get data accessible. But of course, we have to also generate data. I would say that probably, I don't know how this feelings here, but my view is that we have to genotype everybody in Europe. Not only everybody in Europe, but everybody has to be, in order to implement the science, what we already have done, we have to have this DNA array costs 20 euros once in lifetime. You have to do it. It's just even good bottle of wine costs more. But then you can read information from this array for many diseases, including pharmacogenomics. So it's this is a way to really make a forward step, which is leap, which is big step. It's just like to going to the moon. But now science has been done. Data, I know how to generate the data. But what is the problem is that the lawyers come into play, and social scientists, because genetics is something new. It's not only for the lay people. People actually like it, but you go to health professionals, you go to health regulators, and you go to certain groups of people who are against of genomics and genetics. And with social media, they can make a lot of, I would say, harm for the population, because we are not going forward so fast as we need in order to provide better health care, especially prevention. Personalized prevention, this is now the word. And yesterday and day before yesterday, we had many talks about this, what is possible and what's not done yet. So this is why we are working at health data. The European health data space is absolutely crucial to do it. EDIC is crucial. But nothing comes so nice as it sounds. So 1+ million genome project has been for a while already. There's a certain group of people working on this one. The European health data space, there are different group of people working, and EDIC, and the third group. And now we have to somehow to harmonize, otherwise we will get like 3 different things, but we need to have one. So that's why we need more collaboration, more cross-border collaboration among all levels, not only scientists. Scientists can work already, but we have to do, I would say that social scientists has been overlooked. They have very important task to explain to people what it is, how this can be used, and can be used safely on our benefit. So this is my message, that the cross-border thing is absolutely crucial in order to provide better health care for people to live not only longer, but live longer without health issues. You don't want to be 20 years in the bed, but live 100 years. But you want to be healthy, and you get sick in the morning, like me. I would like to get sick in the morning and dead afternoon. I don't want to be in the hospital and all these things. I'm a medical doctor. I know what it means, but But this is what we are working for.
So the European Health Data Space, your opinion really makes actually, because it makes more health data available, it's a step forward for research. And then I was wondering about that a little bit, because you are also a university professor. You probably have a lot of students also working as a young researchers. How do you support them in navigating this European Health Data Space?
Good question. This is very sensitive, complicated document. Just only approved like a couple of weeks ago. And this is not simple document. There's lots of, also it's only opt-out, which is very good, but there are lots of special conditions. When you can opt out, when you cannot opt out, what can be done? And member states have still lots of to say how to implement it in our country. So it's only beginning, and I think it takes a few years how we are going to use it in fully. But of course, we already published in my university. We already had I guess 3 pages about this document, explaining in our own language. Look what this is, and but students, but doctoral students are the ones who are doing research. They have to know what is coming, what it would be possible. Probably for this next 4 years, nothing will change for their PhD track, but they have to know, because soon they probably will be professors. So time goes fast. In Estonia, we have been doing this biobank 25 years, and only now we have a first thing in healthcare, which is polygenic risk score will be used in breast cancer, just to invite high-risk women to the mammography 10 years earlier. Instead of 50, it goes to be a 40. But it took a long time, and and we have hundreds of diseases, which at least 50 diseases we can use a BRS today. But again, medical device regulation, all this, lawyers have lots of to say, and we have to, even our institute, we had to hire a lawyer just to do these documents. I remember when we did research and we discovered the mutation, and next week it was already used in hospital lab just to analyze patients. But now you go for medical, technology transfer unit, and then you talk lawyers, and it takes a year to get paperwork done. Then it comes to medical device regulation. So everything is more complicated.
Yeah, so from what I hear, this is interesting. Yeah? So the challenges might not be so technical in their nature, but more maybe regulatory, and that is actually also, of course, what Mario was touching upon in his first part. And I wanted to focus on this a little bit, because the adoption and implementation of the EHDS is rather maybe top down than on local level, maybe even on cross-border level. And this could indeed result in different solutions on different levels. So it might be really the take-up of the European Health Data Space might be more diffuse. And how do you ensure harmonization in such a situation? I was wondering if maybe you could be passing the microphone back to Mario, because maybe from a more European perspective, the players there, you have also in your consortium, I think, the more European players, the EMA, for example, the ECDC, how they also have their own solutions already before entering the project and entering the European Health Data Space. So how do you take into account all these differences in their way of working? And could that maybe be a part of why these actual use cases are actually the research that you want to do? And that is what the European Health Data Space for secondary use is, of course, all about, research and innovation, how they do not arrive at quickly at a solid research outcome results.
Yeah, I mean, what you're saying is true. It's difficult. So there's no one single easy fix to bring everyone together. And yeah, the regulation provides common rules for plenty of things, not for all. For instance, there's quite little on interoperability in general, at least for the secondary use part. So there is a risk of fragmentation on that part that will not be resolved just by the regulation. So there are initiatives to address it, and you cited the Darwin EU project, who are focusing on a single standard for specific uses, which helps EMA get the data they need for regulatory purposes. So it's a way of achieving something, and the data can serve other purposes. So it is one good practice, and they try to fit their already working solution together with new outcomes or new possibilities from EHDS, which may enable them to get access to additional data sources. So I think it's a nice example of actually, and their use case is one of the use cases which is working quite well compared to others. So I think it is one way to go, but it's not. Yeah, I mean, not every initiative, not every project, not every area of medicine can invest as much money, time, effort, and has maybe a regulatory agency on top, which can give the dynamic to the specific topic. So I think there's also effort needed at other levels. I think we have cited a lot the examples of hospitals, which are a key player. And there, again, will it be a top-down or bottom-up approach? At the French level right now, there's a big funding program to set up hospital data warehouses, which should have a common minimum set of data in a common standard as well. So actually, there the French EHDAH is working together with the hospitals to create that standard and to set up those hospital data warehouses. So there again, it's more of a common effort, both coming from partly from top down, partly from bottom up, and trying to achieve something which has a real impact. So as we know, that hospitals are one of the places that really integrate different data sources. So it's one of the areas where added value can be created. So I'm sorry not to have like a good overall answer to your question, but one is to look at where actually the most important data sources are, and then what really do we want to achieve with it, and then find concrete solutions for that. And so hospitals can be a key player to interact with the HTAPs for that.
Yeah, as long as goal setting is aligned. And I would like maybe to see, Michele, also this problem of diffusion, maybe on European level, but also in the regions. I assume that this might also be problematic when there are different solutions being proposed, because you say the implementation challenges might be the same, but maybe the solutions are then addressed very differently, which might even be competitive, as we even heard that word already before. Is this also what you see when it comes to local authorities and regions?
Well, yes, because as I mentioned, indeed, at least some of the regions across Europe maybe have been moving a little bit faster, than others. We know it's the same with countries, of course. So maybe not specifically solutions, but I don't know, health data strategies, AI strategies, and everything that is related to health data in general. Also, how you produce it. I don't know, telemedicine and so on. Has been already happening for quite some years across Europe. And in particular, maybe that's a point that it's interesting to look at, has also been happening recently, for instance, after COVID with the Recovery and Resilience Facility, where we know that, of course, a large slice of that funding went, for instance, to digitalization of the different countries, and then, of course, it went to regions where that was the case. This is an example where I think everybody that is working, on the implementation of the EHDS, and everybody that is also looking at creating that knowledge, could be the TEDAS joint action, but also the others, to kind of build up and level up Europe at once towards the EHDS goals, will have to take into consideration, because again, let's take the example of the Recovery Resilience Facility. There have been, of course, across Europe several initiative specific projects at regional and other levels that have been, for instance, implementing electronic health records because they were not there before, telemedicine setups, and even in general also building on skills and literacy of population and other professionals. How these things will interface essentially with what's happening with the EHDS, which came a little bit later, I think is going to be important to keep into consideration to avoid, that's not me, I hope, to just make sure that it's we're not indeed kind of either refunding or reproviding solutions that have been searched and applied before. And this is important for the regional, but I guess it's important also for all other levels, could even apply to developing health data related skills for professionals or even citizens and patients or policymakers, because that's also a user dimension that we need to take into consideration. Secondary data used for policymaking, which is of course very important for public authorities.
Yeah, thank you. And I would like to maybe go back to one of the things that you said, that people were already developing solutions before even the EHDS was there. And I think this is also something I would like to touch upon a little bit, because the EHDS aim to find a solution for challenges that researchers and also innovators face when it comes to reusing the data. I am focusing on the secondary use. But is the EHDS enough to address all these issues? Maybe a question maybe for Sophie. Does the EHDS address these challenges properly? Does it take it far enough?
I don't think so. So no, ideally, because I think the biggest added value for everyone, whether it's just benchmarking or first requirements, standard information, or whether it's advanced research with AI, the biggest added value is that the data is structured. Yeah, it's structured, standardized, and we use the same standard. Well, ideally, I would like Europe to tell what we have to use, because apparently we don't get amongst us, we don't seem to agree on anything. So, and I think a lot of people say this, a lot of people are looking at the HDA, even at national level. HDA, please tell us which standard, because we can't agree upon us, between us and the member states, perhaps equally so. So I would actually not be, I mean, of course, you need to be, to some extent, allow some flexibility, but I think Europe can be even stronger in expressing, let's go for FHIR, let's go for OMOP, and anything else tries to be interoperable, so that we at least, because I think people would be helped, because the biggest, if all the data was structured and standardized, anything is possible. So it's almost anything is possible. Federated is possible. AI is possible. So if you have that structure, but then, of course, that is a lot of time and energy for these carers and these healthcare workers that don't have the time. So you need to install resources to do it, to do the work, or give them the time and the space to invest in this registration. And the biggest second step is the regulation. And I really come back to this idea. It's the same what Marco was using as an example. It's the same with EMA, official statistics. It's like, everybody registers in the population register. Everybody thinks this is normal. You register, and the government has this set of information that they know. Every 6 months, they know how many kids will go to first year in schooling. So it's a standard set of information, and the government needs it to run the country and to have policy advice, to create policy advice. Well, the same. You apply much more to the context of health data. You oblige a certain set of information that is there. And if you put it into the code of practice, like adheres, where the official statistics adheres to, you have a mandate to demand data that is already existing. You have to make it open. And there's also, they have to make it quality credible. You have to make it transferable. So there's a lot of regulations that exist already for official statistics that you could easily reapply to health information blocks that you need to run the country. So, and the same principles exist already. So I sometimes feel a little bit frustrated that we are not reaching out much more to other domains where these things can be recycled. But okay, I'll stop.
No, but that's a very clear message, and I think I would like to ask Andres, because we're also running now at the end of the panel. Do you agree with what Sophie is saying here? That putting it into more bluntly, is the EHDS maybe a missed opportunity? Can we take it even further? What does this mean for your line of work?
I would say it's good that it's there. It's encourage people to think about this and do something, but. Of course, we have to do more harmonizations. You mentioned that, okay, OMOP and things, but like a simple thing, informed consent. We have hundreds of informed consent in Europe. And in order to collaborate, whatever you take, informed consent has to tell that, look, you can use these samples of data in collaboration. So which, I don't know what the solution would be, but I would do kind of template informed consent, which is coming from Europe. Every country can modify it, but it still has some basic things which allows us to collaborate. One thing. Second thing, what I'm seeing is lacking in Europe in this area mostly is politicians, and each can do it. Look, this time COVID, and they could really decide in few weeks, put hundreds of millions into this to solve the problem. But the normal time, so it just move very little steps. It took long time to negotiate this data. And now it's quite complicated, especially the secondary use of data. It's of course scientists say, okay, we can use health data in research, but if you just look into this document, quite complicated. So it's so much exclusions, and it's not easy. Normal PhD student cannot get it. So we have to have again lawyer who explains it, how to use it, and what you can do it, and most important, nobody wants to make a mistake. If you make a wrong step, you get into trouble. So everybody wants to play safe, but then we have to have a clear rules.
That's very clear. Thank you so much, André. And I think with this, I would like to conclude this panel. My apologies that there are not any questions, but I hope that some of the panelists might be available during the network opportunity later at in this day, so you can ask them all your burning questions. I think when it comes to challenges, when to implementation, we already heard a lot. Maturity, technical maturity, not only on EU level, local level, national level, legal interoperability and legal challenges. The complexity of the legal framework. It was already highlighted actually by Elina this morning that the EHDS is not a regulation standing at itself. There are more regulations that are actually involved. The GDPR, the AI Act, the MDR was mentioned by Andres, but also of course the Data Act, Data Governance Act, etc. Legal interoperability, regulatory interoperability leading to harmonization of different initiatives, and beware of competing initiatives. But I also heard some positive things. If I can end with that, the EHDS might provide some accessible tools that you can use in order to unlock the rich data landscape that is there in Europe, and might be even a step forward towards better reuse of health data. I would like to thank the panel for their very nice insights, and I would like to give the floor back to my colleagues Janus and Montse. Thank you so much.
Thank you so much, Nienke, and to the panelists. So it has been fascinating. It have been fascinating discussions. Now we are moving on to the final.
Yes, but sorry for interrupting you, Janus. But as we promised to the people addressing questions online, that we will be addressing them very quickly. There was one question to Kathleen Dont. So it is, how does the Health Data Agency contribute to enabling research and innovation for healthcare in Flanders? You have 1 minute to answer that. And very quickly, thank you.
Thank you. Yes, we are taking steps to go for the implementation of the EHDS and collaborating with the HDA that has been established. And at the same time, we are now taking steps to understand all try to align also all the different data holders that need to be on board and to agree on how to proceed further. And a very important aspect is also the cost that is needed. So we are waiting for the elections and next year new governments that will be in place. So we also want to make an estimate of the cost that it will bring to implement everything, because besides the regulation and organization, etc., there's a huge cost associated to this. with respect to data storage, compute, and securing processing environments. So, and this is people tend to be quiet about this, but this is an important issue as well. So we are taking actions and preparing for that.
So am I on? Yes. So the next and the last session will be sort of a continuation of the process that Scanbalt has started already 5 years ago, which was actually to collect feedback from the stakeholders in Europe on the European health data space. From very early days, we just were actually collecting the opinions, some general feedback. And first 2020, it actually was in a form of the questionnaire, or based on what we've finally formulated a declaration, was submitted to the German Ministry of Health during the German presidency, EU presidency. And we continued to do the same during the next presidencies, during the Portuguese, during the French presidency, when we updated this declaration. And based on this process, actually, we were happy to join forces with BioCat, with CIBER, with Health Cluster Portugal, and we are here on the project, last days of the EDAH project. Now, during this session, we tried to continue this in a way that we would like to emphasize importance of the feedback from clusters, but also from the industry. And here is mostly people who are representing some way or another industry organizations. And that's why I'm very happy that also EID Health has been joining us, which was EID Health was actually conducting quite an exhaustive sort of process of workshops during last year or so. So that's why I would happy to invite here to the panel Jean-Marc Bourrens, the CEO of the EID Health. Then we would like to have here Leander Ranken, the Senior Policy Officer from EUCOP, or European Confederation of Pharmacological Industry. Also Aneta Tiskevich. Aneta is the Director Digital and Data at FPI, it's the European Federation of Pharmaceutical Industries and Associations. And of course, Jan-Philipp Beck. Jan-Philipp has a long history with EID Health, but now is a partner at Ventura. And Valentin Plochard, Health Regulatory Affairs Manager at Therapeuta Bio, which is one of the most important organizations. So, as I know, of course, Rabea Knorr, sorry, Rabea, so I just wasn't. Rabea is actually head of department in industrial health at the German Industry Association. Is it correct translation to English? So, but first of all, as we have only 1 hour to try to be effective, so I would like to give floor to Jean-Marc to give actually a sort insights of what actually was the feedback from the EID Health, sort of collecting feedback from different parties.
Thank you so much, Janus. Really delighted to join this panel session and discussions with my fellows, colleagues. So imagine a world where everyone has complete control over their health data, a world where this data not only drives, healthcare, but also fuels groundbreaking research, innovation, and informed policy making. This is the vision behind the European Health Data Space, which is now going forward to enter into force. As a European citizen, I'm really proud of this key achievement from the Commission. ahead of the upcoming election at the European Parliament, as you know. At EITLs, we are dealing with project and activities portfolio building throughout the dedicated flagship call, whereby we are breaking down the silos between innovation, education, business creation, and implementation of innovative solutions and technologies, like the flagship so-called digital transformation of health and care by harnessing the power of health data to drive innovation, research, and public health. So I'm really thrilled to share with you an exciting journey we are embarking on to transform health data management in Europe. So a few words about EITL. So EITL is a community of world-leading health innovators and one of the 9 knowledge innovation communities supported by the European Commission. So we are an EU-funded body and the EIT umbrella. EITL has been established in 2015 based on the principle that when experts from business, research and education work together as one, an optimal environment for innovation is actually created so far. And that we are the things whereby our mission is to drive healthcare innovation and create positive social impact in Europe by integrating the 3 sides of the knowledge triangle. So business creation, research, innovation, and education so far. By doing so, we are creating a more conducive environment so that life-changing innovations can happen and doing things that we cannot do so far alone. So let's talk about the EIT Health Think Tank, which is a thought leadership forum aimed at gathering multi-stakeholder insights about existing and prospective environmental needs and able to generate actually a real-world data for evidence-based policy making and the transformation of healthcare. So our journey actually within this think tank began in May 2022 with the EITL's roundtable series that has been kicked off by the European Commission Directorate's DG Santé with our colleagues that actually decided to steer this think tank together with a sounding board of 18 experts across Europe, like Elina Dragvig, who was a member of this sounding board. So I would like to thank a lot, Elina, for having accepted to be part of this sounding board. We brought together experts and stakeholders to discuss and host a series of roundtable discussions that were crucial in shaping our own understanding and approach to understand the way that the EHDS implementation legislation package will be occurring moving forward. So it's really important to make sure that we landscape on the ground different ecosystems across member states. This extensive and collaborative effort led to drafting the EITL Think Tank report made available a couple of months ago. We released this report at our EITL summit in Rotterdam with our colleagues from the European Commission Directorate DG Santé. 1 month after a significant milestone has been achieved, which is actually the provisional agreement on the EHDS published by the Commission and the Parliament. So you can see here all the discussion that occurred across the member states. The EHDS proposals stands on 3 main key pillars. As you may know, so empowering individuals to take control of their health data, enhancing the use of health data for better healthcare delivery, research and innovation, but also policy making for public health, and ensuring the safe and secure exchange and reuse of health data across EU. So actually implementing the effective change management is obviously critical for successful transitions. So our analysis spans 6 crucial dimensions for a holistic approach. These 6 dimensions provide a comprehensive framework for addressing the key challenges and the way that we look forward to tackle those challenges moving forward. So in total, we are proud to disclose and release over 120 findings and solutions from diverse stakeholders and policymakers, but also the industry sides whereby many pharmaceutical industry, medtech industry, and digital industry participated and contributed to these discussions across member states. This extensive research has resulted in a wealth of findings and actionable concrete solutions. These insights come from policymakers, obviously, health data access bodies, like the Health Data Hub previously, but many others, like in Finland and Sweden and so on. Pharmaceutical, digital, and medtech devices, the industry representatives, health institutions like HTA body or payers, national payers, but also higher education institutions and healthcare providers. And obviously, last but not least, patients organization, because we have to make sure that data share is looking forward to put the patients at the center of everything we do moving forward. So these findings and solutions are right now available within this report. So let's explore the key findings and solutions we have identified. So if you agree, I'm not looking forward to introduce to you all those synthetic slides, even if we've tried to summarize 100 pages report. So I'm not looking forward to, boring you with those findings so far. So I'm going to, let's say, picking up one of those key findings in these slides regarding the different axes or areas that we considered. So enhancing capacity and skills is, as you can imagine, crucial for effective health data management. So we have identified significant needs in that field and strategies to improve capacity and skills. And this is something that when it comes to digital literacy, data expertise in the field of data science, AI, cybersecurity, interoperability, and so on and so forth, we do sense that this is something that we have to consider quite seriously moving forward by upskilling and reskilling healthcare professionals, but also health industry workforce, by gathering a set of dedicated training and courses moving forward. Here, EITLs can obviously provide strong support with our network of higher education institutions, but also gathering our EITLs Academy platform, which is a learning management platform across Europe, with dedicated tools and training programs and courses to upskill and reskill targeted learners, like within the European Partnership for Skills that we are coordinating. This is a new European partnership that we signed 5 months ago with DG GROW, DG Ample, DG ERA, and DG EDAH. And this is a new European partnership which is aiming to tackle the skills gap across Europe. The second part is actually securing obviously adequate resources and funding, which is by far essential for sustaining health data institutions and initiatives. Our findings are highlighting critical funding requirements and resource allocation strategies. So we do sense here that we have to make a kind of joint forces or joint action together with different funding bodies by creating synergies between the funding agencies or funding schemes programs, where again here EITLs is keen to contribute alongside member states and the European Commission funding programs, but also by mobilizing a private investment from industry and chasing a private investment from venture capital funds that are interested in reinforcing the data innovation ecosystems in Europe. So to do so, we can mobilize our colleagues from the European Investment Fund or colleagues from the European Investment Bank. Yesterday, I was discussing with DG GROW about this opportunity to drive strategic initiatives across this ecosystem. So more than happy to join forces with TEDAS2 as well. The third one is actually ensuring high quality data, which is obviously paramount for accurate analysis and decision-making process. So we have to make sure that we can foster a common understanding of data quality from ontology perspective, semantic standpoint, and interoperability perspective, enforcing a kind of inclusive system of quality control at the member states level, and supporting appropriate use of different data sets by connecting existing patient registries or patients cohorts, but also biobanks, and connecting the dots between those existing set of data that are already available as a kind of a quick win moving forward. And then when it comes to the way to understand the relationship between the primary and the secondary data, which is by far key, we do suggest to, not we as EITL, but think tank roundtable series stakeholders, suggests to facilitate the flow of data from primary to secondary user settings by building trust in and the outputs of secondary use and chart the path to closing the loop between those two type of set of data. Last but not least, promoting education and awareness to patients, citizens and caregivers, but also workforce and healthcare professionals is vital for stakeholder engagement. Here our recommendations goes from focusing on the way to enhance education and communication strategies with public and citizen and patients awareness campaign to facilitate the engagement with the open health data space bodies by cultivating trust in long-term data sharing for primary and secondary use of data. So what's next? As of today, the report is published on the EITL's website. We are looking forward to use this work done, the insights, challenges and opportunities which have been identified, and continue our discussions together with partners and key stakeholders across disciplines. How we can use the EITL's network for partners and the stakeholders engaged in the roundtable series to support the EHDS moving forward and actually the implementation of this legislation package. So don't hesitate to employ this think tank by engaging with key stakeholders and experts. Applying insights, again, by implementing the valuable insights we have gathered to enhance health data management. Addressing challenges by tackling the highlighted challenges during the roundtable series. Sales solutions uncovered by putting into action the practical solutions that we have identified, so over 120 findings so far. And setting up meetings between experts to address specific technical issues by supporting the dissemination and communication across Europe and the member states. And last but not least, we are more than keen to support and work closely with EU level partners to support the implementation, to collaborate with REGA. So we may know that we already signed a strategic cooperation agreement with REGA, and I do believe that the regional health agency will be crucial to make it happen. We signed a partnership agreement and strategic cooperation agreement with IHI, and look forward to do so as well with EDAH to help moving forward and make it happen so far. Thanks for your attention.
Yes, so much for Jean-Marc. So I would say that let's try to go. So when we start the feedback from the audience, what do you think, Jan-Philipp? Do we do now, or we just hear some intervention from the pharmaceutical industry representations, or what is your?
If you like, I can quickly run through the feedback that we got from the survey so far, and then we move on.
Yes, maybe it would be good then.
I run there, then I can see my own slides here. And I also realized that I think my picture on this is, it's like sometimes it happens with LinkedIn pictures. It looks like it's from high school. I think I have to change it. So hopefully you still recognize me from that. So my name is Jan-Philipp Beck. I'm a partner actually with Ventura Consulting. We're management consultants in healthcare and life sciences. I got here by working with Janus and also with Oliver Stenzel, who is the one who's actually leading the digital working group in Scanbald. Now he is at another Scanbald conference or a big conference on healthcare in Germany, where Scanbald has a key role. So that's why he cannot be here, and that's why I'm here. My intervention is very short. I want to give you a kind of a status update on where we are with the so-called Scanbald Declaration, and also share a call to action maybe for you to still participate in a survey that we are running to get perspectives from stakeholders around Europe. So very briefly, if you flip to the next slide, I can do this myself. Okay, perfect. Look, so the Scanbald Declaration is a Scanbald declarations have been issued on various digital transformation topics already alongside previous EU presidencies. And this is now in preparation, which should be completed in the next couple of weeks to also address policymakers, of course, in Europe. Has three key, let's say, areas or main statements. One, and it casts the net a bit wider than just the EHDS. One is looking at regulatory data protection and OME to actually remain a key and important incentive for innovation in Europe. So we believe that's a key and important tool. It's a call to the EU to reprioritize biotech and digital health innovation. So also the future Parliament, of course, and Commission. And then finally, it looks at secure health data sharing, and there are 11 key statements in the draft. We put that out. We invited people to give us feedback on those statements, to what extent they agree or not agree to those. And I will not talk you through those now. You can have a look at all of them. 5 was the highest that you could give to them. And actually, we so far received quite a lot of support to the statements that have been crafted, with an average score now of 4.6. So there is quite a lot of support for the key statements that are so far in the declaration. But of course, there have also been some additions made. So suggestions that came, let's say, from those who responded to said, look, there might be a few things you actually still want to include. I want to call out number 2, Jean-Marc, you just mentioned that, around skills and capabilities. That's also something that came out of the EIT Health piece. And number 3, we actually also discussed already today, and I think that has been something you added there, like it was around cross-border healthcare in regions, which I think is a very interesting and important topic that we maybe should make part of it. Now, you're invited to still participate in this survey if you like, on behalf of your institutions or individually. So the call is still open. You can copy the code. We might also share it again, Trine, following this conference. With everyone out there, so that we can then wrap up the declaration as soon as possible. And now, just as input further for this discussion, what we thought we would do with you, despite the fact that time has progressed, but we'll try to be really fast, is we wanted to engage you here in the room, and of course everyone also in online, around 3 key questions. One is actually polling you on your predictive skills on what the future European Commission will be like and what the members of this commission will think. So we would like to know from you how likely you think it is that the new EC will reprioritize biotech and digital health, innovation and competitiveness, of course, keeping in mind that there are a lot of competing priorities out there too. And we invite you to take out your phone. You can, well, you know how this is, right? QR code this. Oh, wow, okay. You already figured it out. So we'll wait for a moment. We don't wait forever, but please feel free to. Okay, a few people think it's not likely. And everyone on the panel, keep it in mind. Maybe it's important background for our conversation now. Let's see. Okay, we'll move to the next soon. 3, 2, 1. Next one, quite likely. So there are a lot of optimists and enthusiasts here in the room on the sector. How confident are you that more secondary use of data for research or data sharing for research purposes will be practically enabled with the EHDS? So it's a bit like I would like to hear from you how likely you think that implementation will actually work. We discussed quite a lot about this. So it's a question like, it's not about all the planning and the great ideas, but is it actually gonna happen? And you are confident. That's good. That makes me confident too. Confident or very confident. Well, many of you are the ones that will need to make this happen. So I think that's great. Let's give it a little bit more time. 3, 2. Okay. Good. Let's move to the last one. The last one now you need to type. This should come out as a word cloud, and we can just leave it there for a moment. What do you think is the single biggest hurdle for implementing the EHDS? We've heard about so many today. It's a daunting list. But what do you think for you is the biggest one? Resources, okay. I actually don't know, Trine, if we allowed people to put many words. let's see, so maybe some people multiply the thing, but that's not actually the problem. Okay. Data. Wow, and it just keeps on coming. Right. Member states are the single biggest hurdle. Oh. Okay, look, we'll keep this going. Maybe we can even share it afterwards, or we post it or something like this. Maybe it's interesting for people to see. I don't want to take more time. Keep it in mind. Let's have a good discussion. Maybe it informs it, and we'll continue working on the declaration. I hope you will help us and hopefully then also endorse it once we are done with it. Thank you very much.
Thank you very much. It would be now fascinating to hear what kind of response or thoughts are starting from the pharmaceutical industry. Let's start from Anna. Aneta, so maybe you can say that what is your, if you are speaking from your organization's view, what is your take on the current situation, and what kind of reflections, what you have heard about from Jean-Marc, from EIT's responses, and how you feel now? Are you confident, and are you sort of alert?
Thank you very much. Well, based on the responses from the audience, I see that we might be actually quite positive about whether we are moving in the right direction to set up an innovation-friendly ecosystem. But I guess that is still to be seen. But coming back to the main point of the discussion, well, firstly, thank you very much for presenting the results of the report. We had a chance to actually contribute to that report, which was really greatly appreciated. I think that the report was developed with a broad group of stakeholders in order to really reflect what are the sort of priorities by the majority, let's say. From our perspective, I would focus more on the challenges that we've seen from the pharmaceutical industry side. But I also wanted firstly to a bit sort of say why actually the data is even important in the context of conducting scientific research, and what are the, in our opinion, priorities are in order to make sure that we are truly creating a system that is workable, fit for purpose, and future-proof. And that is very important given the speed of the advancements in science and technology. So firstly, for our sector, and maybe I should start by saying that FPR represents over 2,000 companies. These are also national associations, big leading pharmaceutical companies, an increasing number of small and medium enterprises. Data is critical to all what we do. So it's from identifying trends, testing hypotheses, developing drug, and monitoring its performance in real life. It is all very much dependent on the availability of data. However, clinical trials data constitute a very small amount of data generated every single day in the healthcare system. Hence, in order to fill the gaps in our knowledge that currently exist, we don't have treatment in many areas, or the treatment is not satisfactory. There is already an increased sort of recognition when it comes to the limitation of data generated in the strictly controlled environment. Hence, in order to start exploiting the potential of the so-called real-world data, so data that is now in the system generated from different sources, and many of them are emerging as well, we need sustainable and predictable access to that data. Hence, from this perspective, the European health data space can be and is a groundbreaking proposal that can create long-term benefits, also motivating the private and public partners to work in a new innovative ways. Nonetheless, a lot has been already said about the challenges and priorities, but I think that we haven't given so far sufficient emphasis on the secondary legislation. So the primary text, the core text of EHDS, remains very high level. And from the perspective of a data holder and a user, and we will be having both roles, we will be wearing two hats, it's very important to understand how we can contribute and how in the future we'll be able to also access that data. So I would focus mainly on the secondary use. However, I wanted to acknowledge that the well-functioning primary use setup of the well-functioning primary use of data would obviously create it's fundamental in order to make a successful framework for secondary use. Nonetheless, for us, indeed, the priorities are in certain provisions that are, again, they remain very high level, such as data categories, which it's not defined well which databases, which data sets are actually in scope. So that might create a further confusion. There is no deferral period after which the data shall be shared. So this is also important from the user perspective to make sure that we actually share the data that is valuable, that is useful for the users. Another issue is related to the data containing intellectual property, where now Health Data Access Body would be the one tasked with firstly identifying commercially sensitive information, then providing sufficient safeguarding mechanism to protect such data. In principle, in the current system, very specific knowledge is required in order to firstly assess the economic value and the serious economic damage it can cause when such a data is being shared without applying appropriate mechanisms. Hence, the data holder is the one who has the best knowledge about the value of the data he holds. And this has been reflected in the final text of the Data Act. Hence, if we are talking about the consistency between horizontal and sectoral legislation, we haven't succeeded in the context of EHDS. So that's another thing that is important, and it might create even further sort of, let's say, bottlenecks in the system, because the health data access bodies might not have even capacity and expertise to deal with this sort of requests. So that's one thing. And another thing, I mean, I think the most debated topic during the negotiation, opt-out. I mean, so it has been discussed that the patient indeed have to feel that they have certain level of control, even when anonymized and aggregate data is being shared for the research purposes or for any other purposes that are legitimate. Nonetheless, now that the way the opt-out would be implemented, it would be important to see whether, first of all, is it implemented in a harmonized way across different member states. And secondly, now the member states can override this right when the data is used for the research conducted by the public authorities. It might have a really detrimental effect on the public-private partnership, which for years has been a main vehicle in developing actually solutions to the current challenges that helps us in advancing with digital transformation. So depriving sort of the private sector from the evidence that can complement our knowledge will specifically impact those areas where we have scarce evidence currently. So this is another thing. And last one is actually the international transfer of data, which again, it's important to maintain the global flow of data for scientific research, because like that helps us to advance on our collective medical knowledge. It helps us to avoid duplication. And again, it's important in the context of the diseases where we lack of evidence, to make sure that we can connect the data from different regions. And here EHDS, again, many aspects would be defined in the secondary legislation. There is also a new category of data, so-called highly sensitive non-personal data. This is something that doesn't exist in GDPR. So still, I wanted to be very concrete, because this is something that hasn't been maybe, we were talking, obviously, it's very important to ensure the phased implementation, to ensure that the countries have capacity, to ensure that we build up on existing well-tested solutions. And this is important for all to give a greater sort of certainty and confidence that the system would really deliver on its promise.
So it was very clear position. So, but if we look, Leander, to your organization is mainly sort of representing small and mid-sized companies. Right. So is it somehow different, your view, your organization view, than what Aneta was
first of all, thank you for cutting away a lot of grass already, Aneta, because we're actually quite aligned on a lot of topics, of course. Indeed, so I'm representing EUCOPE, the European Confederation of Pharmaceutical Entrepreneurs. I see you missed an E there at the but that doesn't matter. Indeed, we represent mostly smaller and mid-sized companies active in biotechnologies, but also pharmaceuticals, medical technologies. But we also, I think 40% or even more than 40% of our membership is active in rare diseases. So think here, for example, about orphan drugs, advanced therapeutics, personalized medicines. So that's why we're also very thrilled about having the European health data space, mostly because having access now to large and high quality data sets for research and innovation is absolutely crucial for the development of personalized drugs, of course, but also innovative drugs. But think, for example, here also about the rare disease community. So data on rare diseases is already quite rare by default. It's scattered at the moment in a fragmented landscape. Clinical trials, a population is limited, of course. So having now one common access point to rare disease data, hopefully also boost research being done in that area. We already touched a little bit upon real-world evidence, of course. If the data are of high quality enough, then being able to link them to each other, that's also good for the collection of real-world data for real-world evidence, of course. But yeah, speaking of implementation, and we were also happy to contribute to the EIT health report. It's quite a daunting task, speaking actually about implementing the whole thing. Of course, as already mentioned in the EIT health report, capacity, making sure that the right governance models are at place. Also, skills. We need to invest in education. We need to have funds both at national and EU level. But if I go back to my membership, it's indeed most of the points that Aneta also already mentioned is the health data access bodies. They are absolutely crucial. They are going to determine when a data request from a data user to your data holder, whether they have to issue the permit and have to also assess whether this is according to the regulation correct. But this also comes a lot with a lot of technical expertise. They will decide eventually whether the data from most of my membership are data holders, of course, that could include proprietary data, trade secrets. That IP is easily to recognize, of course, but trade secret requires quite a lot of technical expertise. So what I want to push for really is that to make sure that we have a harmonized implementation, that all the health data access body across Europe have the same, a common understanding how to interpret the work that's upcoming. I also understood that the Commission is working on guidance for this, so that's good. Those are one of the important issues I'd like to raise. Also, the data quality framework, of course, if the data is of different quality in the Netherlands to in Spain, for example, well, then it goes against the grain a little bit of how the EHDS should be functioning. And for the rest, indeed, the opt-out has been already mentioned, although it leaves a lot of room for member state interpretation of how to go about the opt-out. So what you maybe get is just like the GDPR, where you get a patchwork of 27 different ways of how data can be shared. There's also a little bit of a they mention in the EHDS that because of scientific reasons of public interest, they can bypass the opt-out, but this is up to the member states to decide. So here is a lot of fragmentation going on, and that's not something that we would like to see, of course. Last point, indeed, the international data transfers. I'm truly baffled here because I still don't really understand how it works. So data needs to be personalized in European territory. Once it's non-personalized, the European Commission with delegated act will decide, or with an adequacy agreement, or how we go about this. And we're going to have to see it in the delegated act, of course, but as we go to implementation, these are really things that we would like to see clear up. Yep.
It's a lot of issues that we see that it's actually justifies the position that it's actually for work for decades. So, but we need to move on quickly, and so European Bio representing quite large variety of companies, not only the pharmaceutical companies, but biotech companies and all sort of biotech. So do you have any very specific issues addition to what we have heard already?
I'm afraid I got all my speaking points already taken by previous speakers. But so I'm representing Europa Bio, which is the biotech and bio industry association. So we have rather similar constituencies than Landa and Aneta, from big pharma to smaller, medium biotech and also bioclusters. So we more or less evolve in the same space. And I think, as many of the challenges have already been alluded to, I think I can concentrate on maybe I'm fundamentally optimistic, and I think EHDS is quite an extraordinarily thrilling tool for reasons that Leander has already mentioned, which is typically in the rare disease community, when we look at OMPs and ATMPs, with like having access to data which otherwise would not be available to us for diseases that with a rare indications and small target population. And I think the only point I would really add is the one on secondary legislation, because indeed, of course, EHDS is the first of its kind of data space, sexual data space. So there's still a lot of high level principle in there, and everything will eventually boil down to how we hopefully we with the Commission go granular on how it can be applied. And probably another issue that I would like to mention that's been alluded to in the previous panel is the bottleneck with like healthcare providers. And I think that to me is practically the most potentially jeopardy, putting in jeopardy the EHDS, is that, you know, healthcare providers are on the ground. They will simply not have the time to input all this data. And even if we don't look at broader issues linking to research and innovation, this is to me what can make the entire system collapse. So I think from an industry perspective, we also have to look broader than purely what's going to affect us. But it remains a fantastic tool. Also, something that has not too much been touched upon is the role of the EHDS in regulatory decision making, which I think is also going to have very, very interesting impact, and that we as industry have to understand how this is practically going to affect us. Although in this greater scheme of things, with EMA always having troubles to like process data and having low resources, having access to this data in the regulatory decision making can really foster and provide better health products in the end.
Thank you. Thank you. So I think for now we would like to hear, Rabia, what is, so Germany is of course not this sort of one homogeneous sort of market, because there is several states which have own autonomy somehow, but still you are representing the whole German industry. What is how different is this view what we have heard if we do the pan-European view?
I wouldn't say it's too different, actually. So most of the people, most of the points were made already. I think your members at the German level are our members as well. So when we look at EHDS, we are very positive on that, definitely, as you said as well. Obviously, we also look a little bit critical on the national opt-out mechanisms, being afraid that might fragment data sets too much, and that is actually a thing we experience very much in Germany, with a GDPR being applied very differently across all German member states. So yeah, we have experience with fragmented data sets, let's say. So we are positive that EHDS might give an impetus to using data also for secondary use of data, which of course for us also is the main point we looked at. EHDS is good. There was, I think for Germany, the bigger leap was actually even a year before with the national legislation giving industry access to data for the first time, which is very positive. But EHDS obviously adds to that, making it even easier. Well, we think, and we also see that a little bit with EHDS, is that industry, and we talked about that earlier today, is always a little bit the bad guy at the table. And we are a bit afraid seeing that in the EHDS as well, having industry not so much included in the necessary stakeholder dialogue. So I think it's important at that point to see how much innovation, also innovation funding, is coming from the private sector, and then the private sector should also be included in the stakeholder dialogues, and I think is very much willing to contribute to that. And as all the policy points were made already, I can focus on a more practical project that was also mentioned earlier already, which is Sphinx. It's a data space project we are co-heading within BDI, where we actually build up a data space with, I think, roughly 50 pharmaceutical, but also medtech companies being based on Gaia-X standards, where we try to unite the industry first, because we know in the past it wasn't it wasn't always the industry speaking with one voice on data standardization as well. And now we are very much focusing on that to also drive data standardization more from the industry side, and then also going into the dialogue with the national legislation to see what can industry contribute to the meta catalog and things like that. So I think that's one point I would add to the points made earlier to really include the private sector in the discussions.
So we know that the member states, I mean, European member states might have quite different stance of ethicals and data security issues. If you look for Germany or Nordic countries, where Nordic countries, everybody counts that it's normal to have the personal ID and this is not a secret, and nobody has any sort of big concerns that Big Brother will follow up. Is it some kind of obstacles when you see the data standardization and EHDS issue and this attitude for the data privacy?
I think definitely trust building in Germany has a longer way to go than other member states. We don't have this high level of trust in government as we see in the Nordic countries. When we look at data, we always talk about data protection. We keep saying we should more go in a proactive discussion on data security, because obviously we want to be data secure, but we also need to find a balance, I think, between data sharing at a secure level and not only focusing on data protection. But I do fully agree that we have a way to go in Germany to make that work. And that's also a thing we want to contribute to with our data space project, to build up space and also show in which ways industry wants to use it and how that can be done in a secure way.
Thank you. So before we go to maybe the final round of interventions, I would ask if there are any questions or comments from the audience to the industry partners here. Yes, please.
Yeah, thank you. This is very interesting. I took many notes. I have the impression that we globally agree on many things, and this is great. We agree about the fact that there should be global acceleration. We agree about the fact that a real implementation is necessary. We agree about the fact that it is important that health data can be used by everybody. Okay. So, but I have a question about maybe what is the elephant in the room, or nobody is speaking about. I will summarize it in 5 letters: IQVIA. So, how is it possible that at the moment we have so beautiful projects? And we have so beautiful rules about GDPR and so on. Well, sometimes not beautiful, but okay, that's another question. And how is it possible that at the moment, at least in France and Belgium, I don't know about other countries, medical data from millions of citizens is sent to a big multinational American society? Well, and after that, it is sold to the researchers who can buy it, and that this system is working, and not that the data is available to the researchers, because the data is coming from citizens, is paid in most cases by the public authorities, so, and then sold by an American multinational. So please, can you explain?
This is really intriguing questions. Anybody wants to start? Do you have any? Yes.
But I think it's really hard to comment without knowing the details of the case, and we are not representatives of IQVIA. However, if the data was not used as envisaged by in the consent, or I mean, absolutely, there should be a kind of a legal way to lodge a complaint. So it's a very specific case. I don't think that we can comment on that. Nonetheless, I mean, from our perspective, in the context of clinical trials, we need to comply with a number of legislation, like, I don't know, anonymizing the data, ensuring that we have a legal basis, ensuring that we control who is accessing the data. We need to process the data in a secure environment. When we transfer the data across borders, it needs to be in accordance with GDPR. Hence, I mean, we are a very highly regulated sector because we collect and generate very sensitive data about patient health status. So that then is used to inform decision on safety and effectiveness of medicines. So, I mean, it's hard for me to comment how IQVIA actually accessed the data and how it was used afterwards, but that's definitely a subject to be discussed with the governments actually that allowed for this data to be transferred, even because I understood that was used in the US. So that's quite clear.
Yeah, I mean, I can also not review IQVIA's business model and what exact data sets they have and not, but I think one reason, maybe bigger picture, why it's also so challenging for us here and why we have all these challenges that we need to go through here is that I think there's maybe a distinctively different European way and approach overall to this question, and also the economic model compared to other regions also in the world. And I think in the US, you see much more, let's say, privatization around data. There's much more commercial models possible. And if you then go all the way maybe to China, you have the government playing a totally different role, which I personally think not desirable for Europe either. And I think so part of all these challenges that we are going through here is the reason that we try to find a way to utilize health data for better research, innovation. But of course, we also need to create investment cases around innovation in health, and their data is also an important enabler. So we are trying to make that work. So, and about IQVIA, I think we are not the ones that can speak on behalf and so much about it, but I think that's maybe where the struggle also is, right? And finding the right way.
In the EHDS, the data is anonymized. So the data.
Can you put it a bit closer, because I mean, the mic closer.
Okay, can you hear me now?
Yeah.
Yeah. Okay. So the data in the EHDS that will be used for research and innovation is anonymized. So it's data that shouldn't be pre-identified.
Anybody? No? Okay.
I think we're done with IQVIA. Next question.
Next question. Any other? Yes, please. Michelle? Oh, sorry.
It wasn't the same time.
But Elke, please.
It's just a short question. Yeah. Coming from your point, the real world data, we have two types of data, prospective, retrospective, and the real world data, there's, instead of specific indications, national registries. Is there a plan to combine these national registries together from different countries, knowing that often there are medical different philosophies also behind? So do you have an idea how to solve that?
Use case and swings around that?
Yes, actually, it's one of the pathway that we've discussed around the roundtable series a couple of months ago, and there is obviously a strong interest to connect existing, data repository, especially when it comes to patient registries or patients cohorts that are really strong enough complying with the current set of rules and the legislations that have been published by the EHDS and the Commission so far. So if those regulations in place are fitting with the use of such already existing patient registries across border, that's indeed a potential interesting route to enlarge and connect those existing patient registries across Europe. I know that IHI, Innovative Health Initiatives, already set up a kind of a partnership like EDAH, which is a European network of patient registries to connect a set of data that are, let's say, reproducible, comparable, to get access to a set of data at large scale so far. So I do sense that if obviously those patient registries are, and especially the scientific board, and in which usually patients associations are sitting to defend the view of patients regarding the GDPR and ethics and so on and so forth. So I do sense that it's a really great opportunity.
Thank you. Michel Silvestri, Swedish eHealth Agency. Several of you mentioned the opt-out issue, and I just wanted to comment on that, as you might know, Finland, and with their secondary use law act since 2019, and with the establishment of FinData, I've heard that they also have the opt-out possibility in there, as you might know. I've heard from FinData's director that at this point, not more than a couple of hundred individuals have actually opted out from that system. And that is with a population of around, what is it, 5 million? So maybe that doesn't necessarily be a big problem if you look at it from that point of view. On the other hand, of course, Finland, as the Nordic countries in general, are also known for having populations with high level of trust in the authorities. So that might differ, of course, if you look at different countries in Europe, for instance. Thank you.
I think there's quite a difference across countries, actually. In Germany, we also went for the opt-out mechanism last year with the national legislation, starting from, I think, early next year. And there's already a huge debate on how to opt out and how that is possible. So I'm really curious how the percentage is on that. I think our point with the opt-out mechanism at the EHDS was more that every national government is going for a different opt-out mechanism. So in one country, you can opt out of these things. In other countries, you can opt out of out of other things. And then you have a very fragmented data set, which isn't so interesting for research purposes more. So if we go for opt-out, then it should be harmonized in a certain way.
Thank you for the question. If you look at the original Commission proposal, actually did not include it an opt-out. To say fairly, this was also the stance of the industry in the beginning. As I mentioned, the data is anonymized, but at some point it became also clear that you need to give an option to citizens to opt out. The reason why we wanted to have an harmonized opt-out is indeed for the reasons you already alluded to, is that you may have healthy people that say, I don't want to be included in the system, or minority groups, or people, that are young people that are massively want to opt out. And then you indeed risk the possibility that your data sets become biased, or, scientifically unrepresentable, or that data quality is not guaranteed. So we were pushing for, during the decision-making process, of course, for a harmonized option, but indeed, individual member states always want to have the option to interpret this in their own way. And also because of the pressure of the European Parliament that actually had a harmonized opt-out in their version, had to budge. And now we have a system indeed where you have of course, the legislation itself says that they have to introduce opt-outs that are easily understandable, but they really also leave a backdoor option, as already mentioned before, the term scientific data for public interest. They can even introduce an opt-in there if they want to. So, yeah.
Just 2 sentences on that. I mean, I think the issue here is a bit that also we are talking about the 15 categories of data where the opt-out would have to be offered, and not for all of these categories that would be even possible. In the context of clinical trials, it's just not possible to offer an opt-out on aggregated anonymized data. That's an issue. So we would want a more sort of tailor-made approach per category, or at the same time having a harmonization at the European level. So, and also, I mean, this differentiation by the type of entity, so that a certain, like the public entities, can override this, right? So this is something that I think can fuel further fragmentation. Fragmentation is also resulting in fragmented rights for citizens. That's also an issue.
Thank you very much. So there's one additional question.
I just want to make a few precisions. So the first one is, you said it's something specific, but it's not, I mean, in France, it's about 50% of all citizens who is giving the information without knowing about it, let's say. But my question was more about, so if it is now already since many years possible for this company to, let's say, sell, even if it is not legally, sell the health data for millions of people, why is it so complicated at the moment to really share health data in a non-profit way? Why are there so many obstacles? Yeah, and how can we accelerate, Because I would say I don't care to share my data to a private company, but I would prefer to share my health data to public authorities and that it is for everybody. And just one few very fast comment about we didn't spoke about anonymization, pseudonymizations, but if you listen, I'm not good enough to understand precisely, but if you listen to scientists, it is not possible at the same times to really have a process of anonymization totally efficient and to use it for research. To be very short, because for research you need more than one element, and so after that you can find the person back, but just very short.
Okay. Any comments?
Just briefly on that IQVIA point, what I can offer to you, I think that the limited understanding that I have from the business model, maybe we can take it offline afterwards, because I don't think it's not the same. IQVIA does not have a private sort of European health data space, but I can give you what I know during the break, and maybe it helps, and then we can move to the other questions further.
Okay, so I think we have got to the end of our discussion here, and from the questions and from the livelihood that the discussion, it seems that there is really a lot to discuss and a lot to discuss in a sense also that it goes to the basic issues of European Union. I mean, subsidiarity, how much we give away our autonomy from our member states. So, and that's why it's not easy discussion. So, but I thank you very much for this participation, and I hope that this is not the last time when we are together. Thank you.
Thank you, everybody, and do not leave, because Ninki and I know that you're tired and you want to eat, but the most transforming endeavors take time. EHDS takes time, and this session took time. But I think it's we're pretty much in line with the schedule we expected. And we just want to thank you again, everybody. But we want also to give a couple of words of, you all have your notes, you all have your insights. But what we get from today is, this perspective of 20 people in this panel, plus the people that has been participating from the audience, and some questions online. I think it gives us food for thought. We're asking our panelists in 5 years, in 10 years. We got from Elena a nice picture of what to expect in these 5 years. So according to her insights, we will just be starting the first group of priority categories, which is not bad. And in 20, the second group. So what does it mean for us? The first group of panelists that I have the honor to moderate concluded that we have the regulation soon to enter into force, according to some news that we got. We might have the resources and the skills, the infrastructures, but we need the roles, clearer roles, and all of that, all those that have to be there, that are expected to be there, have to be a little bit more clear, which is their role, what they have to take from there. And this involves talking about things that some of us may not want to talk about, but it is absolutely necessary to keep discussions like today's. And finishing with this panel about the industry expectations, which is it's crucial. It's important to have piloting practices, and it's important following the leads of countries that are going ahead in the pathway, that are showing us how to do that. So we can only go forward. Michelle said that. We have to do it well. So Ninki, what are your conclusions of today?
Yeah, I think Kathleen actually nicely demonstrates that there's a lot of tension for change, in Belgium, but also beyond. Although the landscape might be fragmented in Belgium, in Flanders, but also in Europe, and there are many players who sit or actually want to sit at the table. And in the panel that followed, we demonstrated that the challenges might not be technical per se, although there are, of course, differences in maturity. But challenges lie more in harmonizing diffused initiatives and focus on interoperability. Adding another regulation to the European health data landscape might make things more complex, but however, it can also provide the tools and the incentives to unlock data and use it in a safe and secure manner. And I think also the industry panel shows that we are optimistic, and actually the Mentimeter showed that you are all optimistic too. And I hope this really bodes well for the health of all European citizens.
Okay, thank you. And I have a last 2 comments. One, first, if you haven't, you might still sign this or run the survey for to take your insights for what we expect there. Second thing is that we want to invite you on behalf of Health Cluster Portugal, Scambald, Council of European Bioregions and BioCat to some drinks and some food because you more than deserved it. So thank you very much, everybody.